everyone, and welcome to our Methotrexate webinar. Just one last reminder before we get started that if you would like to listen to the recording in French tonight, you can hit the interpretation button at the bottom of your Zoom screen, and that will take you right to the live French translation today. So again, welcome to our webinar, and thank you for joining us on this Saturday evening. Tonight we'll be presenting on methotrexate and pediatric rheumatic diseases. And given registration numbers, we know that this is a hugely important topic to families, and one where there is so many questions throughout a child's journey on this medication or starting this medication. So we're so excited to be here today to bring answers and to have a really lively conversation with everyone here. And speaking of who is here tonight, we are really excited to have people, families from 56 cities across Canada joining us tonight, as well as you can see a growing international population, which again just goes to serve to show how important and how many questions there are around this topic. To get started tonight, we thought a really great way to kind of get to know everyone who is joining us on Zoom tonight is if you want to use the chat function, take a moment to introduce yourself. You can tell other people where you're from. If you have a child impacted by juvenile arthritis or another rheumatic disease, you might share their age. And if you like, you could even share whether or not you're on methotrexate or your child is and how many years of experience you've had. So we will let people start chatting in the chat function. And I just have a few little notes before we get started with our main presentation tonight. So Cassie and Friends, for those of you who are joining us for your first webinar tonight, we are an organization working across Canada, hand in hand with pediatric rheumatology teams, and really driven and led by patients and parents. So the youth and families affected by not only juvenile idiopathic arthritis, but all childhood rheumatic diseases. Our main pillars are really to provide information, connection, support, and of course to advance research towards our ultimate vision, which is a pain-free future for all kids with childhood rheumatic disease. Tonight would not be possible without our sponsors. So I really just want to send a huge thank you to our presenting sponsors for this evening, and that is Nicola Wealth Management, Abbvie, Amgen, Roche, and Sobi. Again, their support is just critical to providing these kind of programs, along with the support from families and individuals and grandparents and everyone else who makes Cassie and Friends possible. So thank you so much. We are really excited to not just be presenting the methotrexate session tonight, but we, as you can see, have a huge growing virtual education library of all the past events we've done. So that ranges from uveitis, nutrition, transitions, physical activity. So if you have questions or if you are looking for information, please think of cassieandfriends.ca, which is our website, as a really amazing source of information. Not only do we have all of the FAQs indexed and recorded from past webinars, but we work closely with the medical advisory committee of pediatric rheumatologists across Canada to ensure that we have the most up-to-date and reliable information for your family. We also, just I'll mention, have a COVID site as well that is linked to from our website. And there you can actually, especially now with the rollout of vaccinations, you can enter questions directly to our medical advisory committee. So I encourage everyone to look there, and we will have some new guidance coming out soon. So tonight, one of the really special features of our webinar is our live Q&A, and that's not only your chance to ask questions of our pediatric rheumatologist who's presenting tonight, but also of our patient and parent speaker. So I know I just encouraged everyone to use the chat function, and somewhere, I think to the right of that, you will see a Q&A button. So we have collected questions during registration, but if during the session at any point a question comes up for you, I encourage you just to pop it in the Q&A box. And we have left quite a lot of time to really get through a lot of questions tonight. Lastly, you can see a QR code on the screen here. So Cassie and Friends has an online support network. It's a safe and secure app-based application where you can actually meet and connect with other parents. And I was just in there the other day, and there's a lot of lively conversation going on. So whether it's tonight after this session or anytime that you have a question or want to connect with another parent or share an experience, I really encourage you to either use the QR code to sign up now, or later on you can go to cassieandfriends.ca/support network to join. And now for the best part. So I really have the pleasure of first introducing our patient and parent speaker. And this is the first time we've actually had a dynamic mom-daughter duo to present their journey on this topic, and really some insights and lived experiences. So starting with Abbvie Mazzone is now, well, she was diagnosed with juvenile idiopathic arthritis at 15 months old. And since being diagnosed, she has tried many different kinds of medications and treatments, which include methotrexate, not only to treat her juvenile idiopathic arthritis, but also her uveitis. But what we know of Abbvie, and we've had the pleasure of getting to know Abbvie through Cassie and Friends, is that arthritis does not stop Abbvie. Not only does she love doing things like hip hop classes and gymnastics when she was younger, she lets us know that now she's just really into regular teen things, which holds a lot of mystery, and I'm interested to know what those are. But most importantly, in 2019, Abbvie was awarded our Youth Leader Award through Cassie and Friends for her really amazing contributions to Team Cassie and Friends, as well as our Kids Helping Kids campaign. And Abbvie is joined tonight by her mom, Amy Mazzone. And Amy is a mother of two who has really been through all the ups and downs of medication, treatment, and being a parent of a child with juvenile arthritis. Amy has been sharing some really amazing stories from their 12 plus years of journeying with JIA over on our Instagram page. So I really encourage you to go take a look at those and see if you can relate to any, and maybe learn from some of their experiences as you will tonight. The last thing I want to say about Amy is she makes the best cupcake I've ever tasted, as she did with Abbvie for the Kids Helping Kids campaign. And she's also been a really amazing and active participant and supporter of research. And Amy and Abbvie are currently actually working with Dr. Guzman, who you'll hear from later, on a really important study that will really help parents in Canada understand their child's diagnosis. So with that, I am very excited to hand it over to Amy and Abbvie Mazzone.
Hi. Oh, right now we can just see the 5 black screens and the 61 participants, and that we are going to talk to you without really being able to see, which is really weird. But my name's Amy. This is Abbvie. We're excited to be here to talk about Abbvie's journey and our family's journey with her arthritis and her different treatments, and hopefully we'll be able to be helpful and answer any questions you might have if we have had that experience and can share that experience with you. Do you want to say anything?
Yeah, I'm just really excited to share to people who are either newly diagnosed with arthritis or just starting methotrexate.
So we thought we would kind of run through Abbvie's just diagnosis and treatment over the years, and then talk about some tips and Abbvie made a good pros and cons list. So hopefully we'll cover a lot without being too wordy. I tend to talk on and on. At one of the Cassie and Friends family days, when we were there, we heard a lot of parents talk about their kids taking a long time to be diagnosed. And in a sense, we were very lucky with Abbvie. She was 15 months old, but it didn't take long at all for her diagnosis of JIA to be confirmed. She just woke up screaming one day, would refuse to walk. She was running around at 15 months old, refused to walk, wanted to be held, and we could not. You know, you do all those checks when your baby's crying. You check the toes for hairs, you check the diaper, you feel the temperature, and we couldn't figure out what was wrong. But throughout the morning, she kind of simmered down, and by lunchtime was okay. So I thought, okay, maybe she's just in the mood, because we all get moods. And then the next morning, the same thing happened. And I was like, okay, something's wrong. So I took her to a walk-in because we couldn't get into our doctor. So we went to a pediatric walk-in, and he was just kind of baffled. We did x-rays and blood work, but I just in my heart knew something wasn't right. So I took her to Children's Hospital, and the emergency room doctor we saw had a suspicion right away. And it was confirmed a few weeks later. Well, that we went to rheumatology, and then they can confirm it, I think, after 6 weeks. So Abbvie started on naproxen right away, and that kind of helped with the pain, I think, but it didn't really do much for her swelling. So by the time we had our second visit, this is probably now like 2 months after 2.5 months after the screaming morning, they decided to start her on methotrexate as well. So, you know, she's not even 2 years old. She's taking naproxen, also methotrexate, which was just so scary as a mom, because I mean, I actually saved I forgot to bring it over, the methotrexate warning thing, and it's like a giant world map. It's huge. And when you read through it, it's really scary. So I asked a lot of questions. I felt like I was a broken record, and I was searching for answers that no one can guarantee. Like, no one can guarantee that there's going to be 0 side effects, and no one can, you know, predict the future. But I think we got to see Dr. Guzman's slideshow, and when you see the picture of actually the number of serious side effects, it's reassuring. I mean, I say that on paper, but as a parent, it's still really scary. So Abbvie also had joint injections at that time, which was pretty awful. She doesn't remember that one, but we had to hold her down. And we thought she was tolerating the methotrexate pretty well, because she was pretty little. We'd mash it up into things. We were told to put it in things that weren't healthy for her, so she wouldn't develop an aversion to, you know, something full of nutrition. So now she hates maple syrup, and she hates Coca-Cola, because we would eventually, she made the connection. I don't know how long.
Made the connection that I could taste it through the syrup. I could taste the medicine through the syrup when I would swallow it.
Yeah. So she eventually made the connection, and we thought she was doing all right on it. At that time, we could crush up folic acid, and she would take folic acid as well to kind of help with the side effects. But eventually, she refused to take it. So when I was looking back and kind of preparing for this, I was looking back and looking at all the doctor's notes, and I think quite often doctors were like, Mom was reminded to take Abbvie for blood work. Mom was, you know, the importance of blood work. And it wasn't that I was being irresponsible. Just shortly after Abbvie was diagnosed, I had her little brother. And so I had 2 little kids, and trying to take a little tiny kid for blood work was really hard. She didn't even, I think she weighed just 20 pounds when she was diagnosed. She was a teeny tiny toddler for a lot of years. But that's something that when I look back through the notes, I'm like, oh, I wish I would have been more on top of that. So that's in my tips section. Trying to think what else I want to say. So eventually, I think when Abbvie was about 4 years old, 4.5, we were taking the methotrexate, and her disease had kind of settled, like with the joint injections, and she was seeming like she didn't have a lot of active joints. In the beginning, she had both knees, both ankles, a toe, a finger, her wrists at some point. But every time we would give her medicine, she knew, like, even if we changed up what we were sneaking it into, she somehow knew. And the correlation, I think, between not even the taste of the medicine, but how it made you feel the next day, she was like a teeny tiny adorable exorcist and would just vomit everywhere. And we would try a couple times and then in a night, and then just kind of give up and say, okay, we'll do this again next week. We'll try again next week, because her disease was controlled. And eventually, I think after probably 3 or 4 weeks of trying without, I think maybe one of those times we may have got it down. I remember the moment like so clearly in our kitchen, like just, I'm in tears, Abbvie's in tears, my husband's terrified. And I was like, I can't, we're done. Like, I just can't do this anymore. And we had an appointment with Children's and told them, we came clean and said we had to, like, I just couldn't do it. And they didn't make me feel bad or irresponsible. And it was just kind of like, we had to do what was right for us in that time. And so we kind of trucked along, but not for very long, because within 4 months she had a flare again. Her kindergarten teacher, she went into kindergarten, said, I think something's wrong. And sure enough, she had a flare in one of her knees. It was quite bad. She all of a sudden couldn't keep up. And she's never been a big complainer. Like, well,
now I am.
Now that she's a teenager, she's a complainer. But she's never been a big complainer. So she'd complain maybe, you know, oh, it hurts when I do this, it hurts when but also when you have a little kid and she's got a little brother, you kind of wonder how much is arthritis and how much is just being a young kid who's complaining or is upset the brother's getting more attention than her. Or so she ended up back on methotrexate and also had to have joint injections. So we got in for the joint injections really quickly. And at that time, we discussed with the doctor trying to do it subcutaneously, so by injection. And Abbvie wasn't thrilled, I remember. Not thrilled at all, but she was really reassured by like, okay, we can use EMLA, we can numb it. There's all sorts of distraction techniques you can use. And she was so opposed to even attempting to take a pill that she was okay with the injection. Mm-hmm. So we did that for a while. We did that for about 3 years. In there, Abbvie was diagnosed. So we kind of went up and down with the methotrexate. No, we didn't go up and down, sorry. She was diagnosed with uveitis. And at this point, she was also back on naproxen. So she's diagnosed with uveitis. So we had to increase the methotrexate, plus she had to have those awful drops.
5 drops.
They're awful, and she could taste them. I swear she can taste anything. If it touches her skin, it might be her.
Something that has to do with medicine that I don't like, I think I developed some sort of taste to it when it could just be something stinging in the back of my throat. But I will say that it's the eye drops or the methotrexate or this medicine that I'm taking.
Yeah. Well, it could have been the eye drops. You could have, you never know. But yeah, so there was a lot of anxiety around medication because of the side effects of methotrexate. And then she developed an allergy to the naproxen. She got pseudoporphyria, I think that's how you say it, all over her face. And we thought at first, you know, the first time I noticed it, I thought, oh, Odie, like her little brother was clawing at her or something, because he's not here. Otherwise you would know. And then the next day I was like, okay, no, there's more spots. So she had to be taken off the naproxen. She's on these eye drops. Like, it was just, it felt so, it just felt stressful. And yeah, anyways, we stuck with the methotrexate. And I think after about 3 years, she was able to come off this time with the permission of the ophthalmologist and her rheumatology team, which was like probably I just remember being so excited. We saw rheumatology. They're like, okay, if you know, her ophthalmologist says it's okay, then let's do it. And so I just remember I felt like a little kid, like asking to go like get candy or go somewhere really special. And he said yes. And it was awesome. But that didn't last again. And within 4 months, again, she had another flare and had to have joint injections again. I think the doctors really, like they take it seriously because they're kids, right? Their bodies are growing. So they try to get the disease under control quickly so it doesn't have long-term effects. She does have some weird, she has a weird toe and some, misshaped finger, like a little bit of a misshaped finger. But I think generally they've saved her from a lot of long-term kind of growth differences. I don't want to say defects because they're not defects. Yeah, so joint injections and back on the methotrexate. And it was almost, she was at this point not taking folic acid because there was no way I could get her to take a pill. We got it put into a suspension, which cost $100. And it was like drinking sand. I tried it because I was like, oh, you're being dramatic. And it was definitely horrible. And I saw a question about gummies and folic acid, and I was like, I don't know if that person's here, but I feel like we need to invent that, and then we'll be rich. We can be rich.
I will take those.
Yeah.
Anything that I can chew without having some sort of weird leftover taste in my mouth, I will take.
Yeah. So we did try ondansetron for her side effects. And again, even though we were telling her, okay, it's going to make you feel better, you'll feel like way less sick in the morning, she couldn't stomach the pill. And so we tried the dissolvable tabs, but they weren't covered by our insurance. And I think they were like,
worked for a while.
They did.
Well, we could have them.
Yeah, the first time I paid for them, and I was like, wow, that's a lot of money.
They worked for a while, and I could just put it in my tongue and wait a few seconds, and it would be gone. And then just swallow it with some water, and I would feel fine usually for a little while. And in the morning, I would still feel a tiny bit sick, but not as much as I would if I didn't take it. But then I think after a while, we couldn't pay for it. And
well, we could have, but I think by the point, say what you're going to say,
and
because
like
that's what
I just
happened.
didn't like it. I just couldn't take it anymore. Like, because I still can't take a pill to this day. I won't try it.
We have to buy chewable Tylenols for.
I remember when I got my most recent joint injection, and you bought the Tylenol. It lasted 2 days, and I had to take like 5 tablets because I can't take a pill.
Yeah, so that is also under my tips section. Would be to, if at all possible, try and teach your kids to swallow pills, because I think we've talked about different kinds of therapy to kind of get her over that hump. But what happened with the ondansetron and the EMLA as well is that Abbvie started to get anxious. So we would put the EMLA on and the, I think, Terafilm, the Band-Aid over top, and she would just be like, I feel sick, like any kind of smell, the feeling of it.
So after the EMLA worked, so like the cream with the patch worked for a while, and I liked it because it numbed the area, and I couldn't feel when my mom was sticking the needle in me. But after a while, I developed I could smell the patch that you would put over, and anytime I would smell it, like even going into the doctor's office and smelling it, I feel nauseous. And also, like when we would put the EMLA on like an hour before, I would start to feel sick and didn't feel good and knew that my medicine was coming. Yeah, so it did definitely give her anxiety, and that's not to diminish the actual side effects, but I think the anxiety in some ways was worse. So now what we do is she just gets it. We just do it. So you kind of have to do what works for you. We learned about the busy bee. You learned about that at camp. So that might be something that works for kids, where you put the little vibrating thing between the pain and the brain. So that
might be something, but now we're at a point where we've added Humira. So
I think that because the Humira sucks a lot more, it's way more painful. The methotrexate doesn't bother me that as much. It's still, I still feel a little bit sick every time I get it, but that's just normal for me. But I don't try and push my mom away when she's trying to give it to me.
Like she does with the Humira. So, and that's kind of where we're at now. The methotrexate worked from I think 2009, and just 2020 we added Humira. And every time she came off the methotrexate, her disease would flare. So it worked really, really well for her. But she was on the max dose for quite a few years, and she was getting flares still in her knees and then in her foot that they just needed to do like a joint injection under general anesthetic to kind of kickstart, I guess, the Humira. So we're decreasing the methotrexate, but still taking it, and also now taking Humira. And at some point during all this as well, Abbvie, we did get Abbvie to see a counselor through just one of our family counseling places to kind of work through her anxiety and develop some coping skills, which I think were helpful. They aren't necessarily all for a medication or the disease or some, other
Sometimes I remember one day so clearly telling my teacher I don't feel good and I wanted to go home, and him telling me to do like some of my exercises and it not working and still feeling so sick.
Yeah.
But it could have also been that it was Monday and I didn't want to be at school.
It could have been, and it could have been that sometimes you just can't. The mind over matter is your body knows what's happening, right? So your brain can be, and I know you're very strong and your brain is very strong, and you truck through and power through a lot of things, but sometimes, you can't, and that's normal, and I think that's okay. So do you want to go through your pros and cons?
Sure.
Okay.
So the pros of having methotrexate are it helps you with your illness. It definitely helped me because I know a few times that I've been off of methotrexate, I got a flare, but I've had a million of those, but not for the same reasons. But the 2 times that I was off of it, I did get a flare up after a few months. So it does help you with that. But one of the cons of that is it makes you feel nauseous. Well, in my case, it does. Some people it might not, but
yeah, and it might do other things too, right? There's headaches and not being able to eat, or there's lots of ways it can affect you. But however,
another pro is keeps you healthy. So that's kind of self-explanatory, and I get it once a week. Once a week. So I think we're doing it on Thursday now. Yeah.
We try to do it on the same day, and we were very good for a long time. And
now it's kind of all over
Thursday,
the place. Friday. One of those days. And blood work knows that you're healthy, knows that you're okay and dealing. But then also a con of that is blood work too, because I still fight to this day to get it done. So I just hate it. And an arm massage every week, so
that's your pro, right?
That's my pro.
You do this
after my mom pokes me, she will massage my arm for a few minutes to make the pain go away, and different types of medicines that you can take to feel less sick. So like the Emla or the ondansetron, and joints that aren't as swollen and move better. Now, some other cons are anxiety buildup till the time that you take it. Because I know, like I said before with the Emla, I would know that it's coming and I would feel sick. Or I would be going upstairs and seeing my mom getting the medicine into the needle and also start feeling sick then.
Or scream at me.
still a pill or a needle they have to take. Even if it's just once a week, it's still
Hard.
It's still hard, and it still sucks to take it, but it does help you. And trouble healing the rest of your body. So I had a few like little warts on my toes, and for the longest times they would not go away. And
yeah, every visit the rheumatology team would be like, oh, they're impossible to get rid of with methotrexate. But we persevered,
and they're gone now.
And we had several burnings. But it does slow down the healing of things like little cuts and stuff. We have found, at least for Abbvie. I don't think it necessarily does for everybody. We promised Buddy might make a guest appearance, and here he is.
And after a while, your body might start to hate it. So that's like with the different sort, like how I would take the medicine in the syrup, I would start to hate that, or my body would just develop some sort of thing that like hates it. I don't know.
Like rejects it.
Yeah, rejects it.
You just have a reaction to it.
Mm-hmm.
Yeah, it's very normal to have that reaction. Mm-hmm. So we were talking about the side effects, and we said a few things. One thing that made us kind of change the day, so we were going Thursday, Friday, is because the methotrexate can make you feel pretty crappy the next day. Doing it on like a Friday or a Saturday might be better than doing it during the week. The only, I guess, con to that is that you feel
so if you do it on a Friday is like kind of ruining your weekend. I know that would happen sometimes. That's why I always like didn't want to do it on a Friday, because I would want to go out, hang out with my friends, but then feel crappy and not want to go out and just want to stay in my room all day.
Yeah. Which is the next thing, the next day, trying to be able to just give yourself some grace and sleep in and take a rest. And then if you're comfortable enough, what Abbvie did tell her teachers, her teachers knew that you're not feeling well, then hopefully they'll, make some allowances so you don't have to run around in PE or, things like that.
2 to 3 minutes.
Okay, 2 to 3 minutes left. Okay. What are my other tips? Can you think of anything else while I'm reading through my list? Oh, put blood work in your phone. I still don't do this, and it's really important to get your blood work taken so the doctors can take a look at how your child's body is doing and reacting to the medication. And again, not laziness, and I don't think any parent or family is being lazy when they don't get it done. But it is, it's really important, and I know it's still important, and I still do put it off. Can you think of anything else? Oh, there was a question about little toddlers like having different behaviors, like tantrums and stuff. And I definitely think that could be related to the medicine, because I think too, when Abbvie was little, like she would whine about different things, and I just kind of was like, oh, she's in a bad mood. But it is, I think, a way that they can, not always, but I think it is definitely a way that they communicate to us. So I think that even though it's hard to be really patient with toddlers who are constantly tantruming, but it might make you feel a bit better to know that it could be the medication, and then within a few days, hopefully they'll be more normal or back to themselves. We could probably talk forever. It's been a long journey, but Abbvie is a tough nut, and she has a really good team of doctors, and we're really happy to be here and be able to share, and hopefully we can answer some questions after. And hopefully your journeys with your kids you feel supported, and you're taking care of yourselves when you're taking care of your kids.
Yeah.
Okay. Thank you.
Thank you so much, Abbvie and Amy. That is exactly the reason we start with patients and parents and like real life stories, is because going from that and then into the medical information, into the research background, just gives such a good context. And you've just described so much of the roller coaster of childhood rheumatic diseases that at Cassie and Friends we hear about every day. But what I loved was that you talked about the stress and the overwhelm and the pain and the side effects and emotions, but I also saw come through the coping and all the way to the thriving, like just even the way you interact, and Abbvie, the way you talk so strongly about your preferences. I think that those are all amazing things and so much to learn from in your presentation. So I'm just gonna go back to our slides, and now we have an opportunity to hear from Dr. Guzman. So Jaime Guzman is very well known to our family here at Cassie and Friends. He is a pediatric rheumatologist at BC Children's Hospital. And Dr. Guzman is also, I think, one of the most exciting researchers that we have the opportunity to collaborate with regularly at Cassie and Friends. And Dr. Guzman's research really centers in on helping families better understand their child's disease and even predict what the future might hold. So he has really published some groundbreaking and pivotal research in this area. And we've been really, really fortunate to work with Dr. Guzman, not only in that respect, but also having him as a speaker at several of our past Cassie and Friends Family Day conferences. And also he undertook quite an amazing feat in support of Cassie and Friends and all kids and families affected by rheumatic diseases, which I think he is going to tell you about in his presentation. So with that, I'm very pleased to introduce Dr. Jaime Guzman.
Thank you very much, Jennifer. That was a very gracious introduction. And good evening, everybody. It is my pleasure to try and provide a little bit more of the medical perspective about this subject. And then hopefully we will have lots and lots of questions in the question period and go over things. I did prepare a few slides, and so I'm going to show them now. And hopefully they will help me explain things better and make more sense of some medical things that sometimes can be complex. I hope you are able to see those slides clearly. So as you know, the topic of today is methotrexate, and even though we are describing the use in juvenile arthritis, in reality, methotrexate is used in quite a large number of other rheumatic diseases of childhood. It is commonly used in kids with dermatomyositis, with lupus, with CRMO, with a number of the diseases that we look after in pediatric rheumatology. I always like to start going back to the patients, and this is not a real photo of a real patient because of confidentiality reasons, of course, but it does reflect a situation that I often encounter in my clinics. It's not unusual to see a new patient, maybe a 3-year-old, maybe a 4-year-old, that comes to us because of swelling in the wrist and fingers in this case. And after an assessment, I may turn around to the families and say something like, we should start methotrexate and naproxen. And from time to time, people can, if they have heard about methotrexate, they may come back and say, doctor, hold on, why will I want to put my kid on chemo? And so I'm going to try to focus on some of this discussion in the role of methotrexate. But before that, I want to go to a little bit of the basics so that I make sure that everybody has a little bit of the basics as a common background to our discussion today. So the basics. What is juvenile arthritis? Well, we use the term JIA, which means something very simple. J for juvenile, something that starts before the 16th birthday. I for idiopathic, which is a fancy medical way of saying of unknown cause. And A for arthritis. And arthritis means joint swelling. In this case, as you hear, joint swelling that lasts for more than 6 weeks. As you hear from Amy earlier, sometimes at the beginning, when it is an inflammation in the joints of short duration, we say we need to wait. And the reason for that is because there are other reasons why arthritis may be present. And the most common causes of that will be reactions to viruses, you name it. And typically they go away. That's why before we apply the name or the diagnosis of JIA, typically we need to wait for a number of weeks to make sure that it is indeed chronic. So juvenile arthritis and many other of the childhood rheumatic diseases have at the root what we think of as misdirected immunity and inflammation. Why misdirected? Well, because it's aiming for the wrong target. Normally, immunity and inflammation help us fight infections, but in this case, they are actually affecting the joints. Sometimes it's misdirected because it's too much. You know, for example, it is normal to have certain reactions to defend the organism, but if they are much more than what normally are, or if they last too long, they start being problematic in their own, irrespective of what the initial trigger was for the problem. And because of these reasons, because the key in many of these rheumatic diseases is misdirected immunity and inflammation, that's why most anti-rheumatic medicines attempt to dampen down that inflammation and immunity. How does this work? The way I understand it is we basically looking at first the identification, think of it as tagging, identifying and tagging elements that need to be taken away. And then that is the immunity, is the tagging part, making sure that the body identifies those things and they put a tag on them. And most of that work is done by the white blood cells. And then once they are tagged, then the inflammation comes in and gets rid of that, gets rid of the things that were tagged. And what would you typically use that for? You use it to get rid of infectious agents like bacteria, like other kinds of infections, or to get rid of damaged tissues. Is normally in the normal healing and repair process, if some tissues get damaged, they need to be tagged and removed so that we can start again the healing. And the first thing is that is the same system that is used to get rid of cancer cells. Interestingly enough, humans normally produce cancer cells throughout their life, but there is this immune system that keeps things in check, and for the most part, it works, and it removes those cells. Now, all of these medications, as I said, anti-rheumatic medications, most of them, the main function is to dampen down that immunity and inflammation. And we have, thankfully, many of them. But to think of them, I typically tell to families, think of it as 4 main groups. Yes, there may be different names, and some names are almost impossible to pronounce, but think of these 4 groups. First one are the anti-inflammatories, things like the Advil, naproxen, and there are many of those. But they are basically kind of the first line to start treatment typically, because they are very well known, they are simple, and they can help quite a bit with pain and with inflammation. Then you have the second family, which is corticosteroids. And as you hear from Amy and Abbvie, she has gone through quite a bit of joint injections. And a parent in the chat was commenting about prednisone. Sometimes, if there are too many joints involved at the same time, we use prednisone, which is a form of corticosteroid that is taken by mouth. That also happens in other rheumatic diseases. For example, in lupus and dermatomyositis, it's not uncommon to need to have prednisone at least at the beginning. The third group is what we call disease-modifying anti-rheumatic drugs. That is a whole thing there. For sure, we call them DMARDs. All it means is that to differentiate these medications for the others, we group them together and we say they are disease-modifying because they can actually prevent long-term damage from the disease. And methotrexate is in this class. There are many others. The last group of medicines that I typically tell people to start, so they get a sense of the different groups, the different options, is biologic medications. You hear about Humira. The generic name for it is adalimumab. There is etanercept, there is tocilizumab. As I said, some of those names are just impossible to pronounce. But in the whole, these are all biologic medications. They are ridiculously expensive, but they are also very powerful. Now, not receiving treatment for a rheumatic disease also has pros and cons. Trust me, I was there at a time when we did not have a lot to offer, and the results weren't pretty. I saw kids die from rheumatic diseases. I saw many kids become disabled. I do not want to see that again, ever. Problem is that by the time long-term damage becomes obvious, let's say when a kid that is like Abbvie was 2-year-old, by the time they are 22, if the joint damage becomes obvious by then, at that point there is very little left to do. The damage has been done. So when I talk to parents, I say, yes, it's important to look at the now about trying to control the pain, trying to control the inflammation. But also think of this as insurance. You are trying to make sure that when she becomes 20, 30, 40, all her joints are working properly and she's able to work, have a family, do whatever she needs to do back then. Of course, no given treatment means no risk of side effects and no costs. Those are pros, but as a parent, I certainly wouldn't weigh that much not having costs. When your child is sick, you want to do whatever you can to help them. So then you have an issue of balancing treatment. You have 4 different groups with different mechanisms of action, different possibilities of effect, and some side effects. And you have to balance that. And sometimes you don't get it right. And so what do you get sometimes is under treatment. You have a child that is in pain, that may develop joint damage and disability, and that may miss a chance to stop, to arrest the disease. On the other hand, if you overtreat, then you have more medications that are necessary, and taking medications, as you heard from Abbvie, is not fun. Whether they be pills, whether they be injections, it's never fun to take medications. They actually always remind you that you have a disease, that you are different, and that is not fun. And you can have risks, such as infections and other risks. And I'm gonna go into a bit more detail specifically for methotrexate in a few minutes. And of course, you have the costs. The reality is, for example, the example of biologic medications, they can be very powerful, but some of them can cost $100,000 a year. Who can afford that? So that's why you have all this complicated system of insurance and who's going to pay for the medication and that kind of thing. But let's go back to the key of the topic today, which is why did the parents tell me, why will I put my kid on chemo? Is methotrexate chemo? What is chemo anyway? A little bit of the methotrexate history. This medication is not new by any stretch of the imagination. It was first made shortly after the Second World War II, 1947. Initially used to treat leukemia. And fun fact, the first time we were able to actually cure metastatic cancer, it was with methotrexate back in the 50s. But more of importance for today, for us here, is when did we start to use methotrexate to treat rheumatic diseases in children? And that was in the late 80s, primarily because we noticed that in adults, it had been working quite well. And so then we adopted it. And then there was this very important study published by a group of researchers in the United States and in the then called USSR, and ended up being published in the most well-regarded journal in medicine, which is the New England Journal of Medicine, and it clearly established that methotrexate works for JIA. In fact, the methotrexate is in the list by the World Health Organization of essential medicines that are recommended that every healthcare system in the world should have access to methotrexate. It is available as a generic medication. What is the difference between generics and non-generic medications or brand name medications? It has to do with patent law. Most new medications are on the protection of a patent for at least 20 years. And after that, other people can make the same medicine. The issue is that when a medication is available as a generic medication, there is not much interest or incentive for pharmaceutical companies to promote its use anymore. Those principles of chemotherapy, meaning how the medications work to help treat cancer, were by a large extent the work of these three people. And for that research done in the 50s, they end up receiving the Nobel Prize of Physiology and Medicine in 1988. So yes, we are talking about chemotherapy, and yes, methotrexate is chemotherapy. Now, the problem is that sometimes words take meaning on their own. Chemotherapy, this is the definition from the Canadian Cancer Society, is medications to kill cancer cells. That is clearly good. In fact, you can cure cancer because we have medicines that do it. But in everyday language, common language, chemo has become synonymous of bad because it has been equated with the side effects. And when Anna's parents tell me and ask me about this, that's what they are implying. Chemo is bad. Why will I give it to my kid? Now, I want you to take what I'm going to say with a grain of salt. I'm a little bit of a nerd, and I'm a scientist. I like facts. So this is my perspective. A substance is not good or bad. It is how you use it. Take the example, water. Water is great. It is a source of life in the right amounts. If you have too much, you die. Thousands of people around the world die every year because of drowning. Methotrexate is not different. In the right amount, it can save you, and if you have cancer, it can even cure it. In the wrong amount, it can kill you, yes. In the right amount, we know for sure it prevents pain and disability in children with arthritis. It also helps prevent problems in kids that have dermatomyositis, lupus, CRMO, and a number of other conditions. The one that we treat every day is, for example, uveitis. It can prevent blindness because it is effective in controlling the inflammation in the eye. Now, all substances have the possibility of harming people. It depends on the amount, it depends on the circumstances. If you do the research, you will know the potential side effects of any medication. If you tell me that a substance or medication has absolutely no possibility of side effects, you don't know what you're talking about. You haven't done your research. If you know something, you will know the side effects. And this is controversial, again, it's my perspective. But I hear this from time to time. If it is natural, it is good. Well, curare, I don't know if everybody knows what curare is, but it's something that is 100% natural that the native people of South America discovered they could use to hunt. And it's one of the most powerful toxins known to science. And yes, it's 100% natural. So what are the pros of methotrexate? It is the most commonly used DMARD in juvenile arthritis and in many other rheumatic diseases. It decreases joint inflammation in about 70% of patients, and in 60% of patients can lead to full control, like the case with Abbvie, that we hear about, Abbvie. And 60% of people with methotrexate that have arthritis, you use it, the disease goes away. Remember that I talk about the amount and the right amount. The doses that are used in juvenile arthritis are about 1/50th of what they use in cancer. So when you go to the pharmacy and you get methotrexate, you're going to get, I don't know, a pamphlet, a whole pamphlet of possible side effects, page after page after page. And most of those apply to when you use in cancer. You are using doses that are 50 times more, sometimes 100 times more than what we use to treat juvenile arthritis. The maximum dose that we usually use in juvenile arthritis is 25 milligrams once a week. You can give them as tablets or in their skin, as you hear from our family. It's also effective in many other diseases, dermatomyositis, lupus, vasculitis, and it helps decrease the need for corticosteroids. Some of the comments in the chat mentioned that some patients need prednisone, and methotrexate can decrease the need for prednisone, and that is another reason why we use it from time to time in kids with rheumatic diseases. There are some cons. There is some dampened immunity, which could increase the risk of infection, could induce some delayed healing. It works slowly. It doesn't change the symptoms anytime soon. You start it, and it's going to take 3 to 4 months to see the full effect. But if you get the full effect, 60% of kids makes the arthritis go away. It does require blood work, as you hear, because we want to monitor how the liver is doing, how the blood counts are doing. If there is an issue with those, we adjust the dose of methotrexate or we stop it, and then we don't have any permanent damage, but we need to check to make sure that that is not the case. But the big one is what you have here already, is that it does induce nausea, sometimes vomiting. Not in everybody, but about 50% of people can have significant issues with this. And not only nausea or vomiting, sometimes it's more poor appetite, you just don't feel like yourself for about 24 hours or so. So what about these risks of infections, etc.? each of these squares is 100 kids with juvenile arthritis. And you can see here 10,000 kids in this slide. And here you can see the number of people that may develop an infection or issues with the possibility of malignancy. So yes, there is some risks. We also know that juvenile arthritis in its own increases the risk of malignancy. To put this in perspective, not because I want to minimize the risk, but just so that you have a sense of what these numbers mean. Here is the risk of bicycle injury in Canada. Same thing, 10,000 kids. And you can see the kids here in yellow that end up having to go to the ER because of an injury related to bicycle, and the ones that end up admitted to hospital. So let's go more into detail about this issue of the nausea and feeling unwell, because that is one of the main issues with methotrexate. Well, it is not just nausea and vomiting. It is something that we call methotrexate intolerance. And it is a learned association. If you have, for example, the color, some people develop just aversion to the color because of the association. You know that the methotrexate is a little bit yellowish. And some people just develop aversion to that specific color. We hear about aversion sometimes to the smell, just because your brain associates those things. And this is not voluntary. This is not something that you choose. It's just the way the body and the mind in a human person work. And it is more of an issue in kids than it is in adults. So this learned response can include anticipatory nausea. Anticipatory means even before you receive it, you may already have nausea. And then after you take it, you could have abdominal pain and nausea. But it can also include a behavioral component. So kids, particularly they are very young, cannot communicate things by words. And often you have irritability, crying, just refusal to get the medicine. When this gets bad, it's very tough for patients, for parents, and for everybody basically. And when it gets to be too bad, it may lead to inability to continue on the medication and the need to move on to biologics or something else. Because it is important to try and deal with this, we are currently doing a study. We call it OPT-JIA, which basically we're testing ondansetron, the medication that you hear before, to prevent methotrexate intolerance. And this study was funded by the Arthritis Society. So what we are trying to compare is using ondansetron from the start, from the very first dose of methotrexate, versus what we commonly do nowadays, which is we add ondansetron if and when there are issues with nausea. A trial is very important because without a trial, you will actually never know for sure if adding this one way or the other does more good than harm. The problem with using it once the nausea is developed is that often it doesn't work. And in fact, when you use methotrexate in kids to treat leukemia, you will never dream of using that methotrexate without using ondansetron or similar medicines ahead of time. So what we're trying to do is, can we do the same at a smaller dose once a week from the very beginning? Ondansetron is also a generic medication now. It's still expensive, but not as expensive as it used to be. So this is what our trial is about. We are hoping that we can increase the number of people that have no intolerance, that are okay with methotrexate, to more than 75% from the current 50%. We know from studies that about 50-50 is the magic number. Of about 100 kids that you give methotrexate, 50 are okay with it, don't have much of an issue. The other 50 can have this intolerance, and sometimes it can be severe. This is what Jennifer was referring to. 2 years ago, in 2019, we organized through UCAN and through Cassie and Friends this event, cycling trip, about 200K from Lake Louise to Vancouver. And yes, I did manage to finish the whole thing. I always like to finish my presentation with this photograph. Here on the left, you see what I saw when I started in pediatric rheumatology. I don't know if you can see it from your screens, but it was not uncommon to see kids permanently on wheelchairs, and also kids that, you know, all of them had this posture. You probably cannot see it, but that is a very characteristic posture of damage to your shoulders, your elbows, and your wrists because of arthritis. Nowadays, we almost never see that anymore, partly because of methotrexate, plus other things that new treatments that have advanced in the interim period. That is basically what I wanted to present today. Thank you very much for attention, and I'll pass the mic back to Jennifer.
Thank you so much, Dr. Guzman. I learned so much from your presentation, and I know Abbvie and Amy are gonna pop back on and join us. And we have about 20 minutes for our Q&A, and we have a ton of questions that have come in. So I'm excited to get started. And I'm seeing some come in right now as well. So the first thing that I think we're just going to start sort of with the big question, because there's been quite a few questions on this, is why is methotrexate used prior to biologics? Why not just start with biologics? And this question's for you, Dr. Guzman.
That's a very good question. And there is the theoretical and the practical answer to it. Okay. The theoretical is we have never tried biologics alone in kids in any trials. They have always been tested with methotrexate. And the other part of the theoretical issue is we don't have 20 years experience with biologics in kids. Mm-hmm. And we are always very worried of, is it possible that there are going to be long-term consequences? They are more powerful medications. They depress the immune system considerably more than methotrexate. Mm-hmm. That said, as we learn more and more about biologics and more studies are coming about, we are seeing very little of those fears that we had originally being realized, which is good. That is the theoretical and more of knowledge base. The other one is the practical. Who's going to pay for them? Because if you compare the cost of methotrexate to the cost of biologics, they're about 100 times more expensive. And I can tell you that the healthcare systems that are universal, like the ones that we have in Canada, if they use the funds for that, they cannot cover other things. And so that is kind of the issue. Of course, you know, if I had $100,000 to spare and my kid has a problem with arthritis, I may consider it, but not a lot of people can do that.
Mm-hmm. Mm-hmm. And I mean, I think what I want to reiterate is what I heard from you loud and clear is that in 60% of kids, methotrexate is completely effective to the point of remission. And so I think that that's a really important, piece to remind ourselves as we have these questions about, biologics versus methotrexate, is that this is an effective medication.
Can I add something to that too?
Mm-hmm.
Even though biologics are quite powerful, when you actually look at the data, you get about the same. About 60% of kids, biologics work very well. So they don't work for everybody either. Mm-hmm. It's not like you have something that is 100% effective. That's not the case.
Yeah. And I think, when I look at our questions that we're getting to, the bulk of them are about side effects. And I think that that's what we, it's not so much about the medication choice. It's about let's, figure out how to make the most of this medication that we know is helping our child. And so I'm going to put this next question over to you, Abbvie, as we get into a conversation about side effects. But what do you like to have for breakfast the morning after you take your methotrexate?
I like to eat the same thing almost every day. Even the morning after. It depends on how I'm feeling, or if it's the weekend. If it's the weekend, I don't eat anything in the morning. I don't wake up till like 12.
Really embracing it.
Want to be honest. But I usually eat like an egg sandwich every morning with like a little bit of fruit or a banana before I leave for school.
Do you have many side effects from the methotrexate the morning after, and how long do they last?
Sometimes I do. Most of it is just feeling nauseous.
Mm-hmm.
And also I think feeling nauseous and then anxiety from school.
Yeah.
And then, but yeah, it's...
Yeah, I would say it's mostly nausea and anxiety.
Mm-hmm.
The next morning, it seems a bit better now. I don't know if it's because her dose is lower or if she just is used to it, but she, usually feels pretty crummy in the morning. But we do right at bedtime, so then she can just go to sleep.
And usually it lasts, it depends on how sick I feel. Sometimes it can last a while, but sometimes it can just last like an hour or a little bit less than an hour.
Mm-hmm. We had a question about some other side effects that some other families have experienced. And so one younger child, and if you don't have experience with this, Abbvie and Amy, maybe Dr. Guzman can weigh in, but itchy feet and hot, cold sweats, particularly at night around the methotrexate shot.
I don't think I have the experience with those.
That's interesting. Itchy feet are the worst.
Have you heard of those, Dr. Guzman, specifically with methotrexate use? Hot, cold sweats and itchy feet.
I haven't, but I have to kind of frame this in that, we know about the most common side effects, but everybody's different. The human body has a lot of variations. And so even though I haven't heard of this one specifically, I have heard of other kids that report weird, unusual sensations just around the time of the methotrexate. And we don't have all the answers, but I have heard of these weird sensations on occasion.
And then I think in younger children, it comes to some of the other questions that have come through, is that it's like such a balance between the side effect of the medication and maybe some of the anticipated responses or aversion, and especially in younger kids, behavioral because of that anxiety or aversion, or physical side effects directly from the medication.
There may be also the element of trying to put some words to describe a sensation that they are feeling that is just hard to describe. And people try to kind of draw to comparison with other things.
Yeah. And for those questions about like ways to reduce anticipatory nausea or deal with anxiety, we are going to get to some of them after the session by email, and also send out the link again. One of our past sessions was anxiety and other behavioral depression, et cetera, issues in children with rheumatic disease. So we had a clinical psychologist help with some of those strategies, and we can definitely remind people and share that link as well. Another side effect question was, how common is dizziness with methotrexate?
I
Oh.
feel,
I think that's for Dr. Guzman.
oh, but I
No,
feel like
no, go ahead, go ahead.
Yeah.
it could have just been feeling like from the nausea, but I don't think I've ever gotten like really dizzy. But
Go ahead, Dr. Guzman.
Oh, that one I have heard not infrequently. That and headaches.
Right.
Headaches, dizziness, that is not unusual to have the day after methotrexate.
So maybe some questions now about administration. So there's a lot of questions about oral versus injection. Is one more effective? Does it just depend on the age of the child? Dr. Guzman, do you want to start with that one?
That is a controversial subject, and the way I look at this is, it's likely that subcutaneous is more effective. Is not more effective, but you basically get more of the dose into the system, because every time you take something by mouth, some of it doesn't get absorbed. You use it under the skin, you are getting the whole amount. And so for that reason, some people believe that it should be more effective. But the reality of it is that we don't have a good study to compare them to say they're more effective. The second thing of that is, does it make a difference for side effects? You know, if you take it by mouth, does that make it more or less likely that you will have issues with your tummy or nausea that you take it by injection? Again, another controversial subject. The best studies that we have, actually the frequency is about the same.
Interesting.
But that said, sometimes switching a kid from one way to the other helps. If they were in injections and they were having issues and you switch it to pills, sometimes it helps, or the other way around.
Interesting. Amy and Abbvie, one of our viewers tonight picked up on that you give the methotrexate injection in the arm, and she was actually told to do it in her stomach, and she was just wondering, did you have experience with that? Were you told arm? Had you heard about potentially doing it in the stomach instead?
We were told arm, and we were taught to do it in the arm. I think our nurse said we can change the spot, but I don't think we've ever had to.
just switch between arms.
Just switch between arms. The Humira we have to do in the stomach or the thigh, but we haven't tried thigh.
I think we tried it once, but I didn't like it.
She didn't like it. So we've always done it in the arm, and that's just the way we were taught. But yeah, that's interesting.
Dr. Guzman, is there a preferred site? Does it matter?
From the point of view of the medication itself, it doesn't matter. Whenever you have enough tissue under the skin, you can do it. That said, the thickness of the tissue is different in different parts of the body, and so it may be easier in certain regions. And also the nerve endings that we all have in our skin have different densities. In some areas of the body, they are much more sensitive than others. And so my sense is, if you're having trouble with one location, try a different one. Now, people, when they get trained, it's better to kind of focus on, okay, this is what we're going to do, and walk them through it. But from the point of view of, is there a contraindication to do it in a different part of the body? As far as I'm concerned, from a medical point of view, there is no contraindication to do in another part of the body if that works well for somebody.
So one of the other questions we had around side effects, and I'll give this back to you, Dr. Guzman, and then Abbvie and Amy, you can say if you've had experience, but when you increase the dosage of methotrexate, should you anticipate side effects to be worse?
Let me focus on should you anticipate.
Mm-hmm.
If you anticipate something, it's going to happen.
Right.
So just be careful. Now, is it true that the more of a medicine that you get, the more chances that you will have side effects? Yeah, it is true. Now, it's about the amount. The more you have, the chances side effects are going to be larger. But I just want to cautious about anticipate. Mm-hmm. The human mind is so powerful. If you anticipate something, it's going to happen. And we know this from trials. If you tell somebody that they are going to get a medicine and you give them a sugar pill, they will have the same effects. That's just how powerful the mind is. So don't anticipate. Focus on the positive. Give it a trial and see how it happens.
Right. Good tip for parents when the increase is being made, just not to even go into a correlation with side effects and let that happen on its own. So there are also quite a few questions about long-term effects of methotrexate. Can a child be on methotrexate too long, Dr. Guzman?
That is a very good question. And something that is obviously very important for parents to consider. What I can tell you that because methotrexate is so old, we have patients that have been on that for decades. And as long as you do your monitoring and other things, we haven't seen much in the way of long-term effects. A word of caution, though, that don't assume the same pattern of issues with methotrexate to treat leukemia, cancer, and with juvenile arthritis. We do know that if you use very high doses to treat leukemia, and sometimes it is put into the spinal canal in kids that have leukemia, then you could have a number of long-term consequences, but those are basically unheard of at the doses that we're using for juvenile arthritis.
And how do, and I know that Abbvie, you shared that you've recently started Humira as well. Maybe we'll start with Dr. Guzman, but like, how do methotrexate and biologics support one another or work together when they're prescribed at the same time or added or adjusted together?
That is a good question and connects with something that we mentioned before. Thing is that nowadays, for a new medication to come and be available for use, there has to have properly done trials. And all of the trials of the use of biologics that we have done so far, all of them have been in combination with methotrexate. So we don't know for sure if just using the biologic on its own will produce the same effects. In adults, there are some studies of the comparison, and it seems that it potentiates the effect, that you get the better chances by combining the two than just with the biologic alone. But in kids, we just don't have the studies to show that. Maybe the same, we don't know.
And Abbvie, how are you feeling with the addition of Humira?
I think it's okay because I get the Humira every 2 weeks, not like the same like every week as I like because I get the methotrexate every week, and I don't think It's not much of a difference. We don't usually do it on the same day. So like when I do have my Humira, we don't usually do the methotrexate on the same day, because the less needles I get, the better I feel.
And I think that I don't know that I've noticed any side effects with her with the Humira at all, other than that just the injection is actually very painful, like it burns, from what I hear from her and what I have read. But I haven't really noticed anything else. Yeah.
So we have a ton more questions and we have just a couple minutes left. So I just want to let everyone know that we are going to do our best to go through all of the questions we weren't able to answer and reply to them by email. We're going to go back to our medical advisory committee with the help of Dr. Guzman, as well as Abbvie and Amy, to make sure that we specifically answer questions. A lot of them have to do with like guidance and choices and like splitting doses and when to give, and maybe the addition of one question just came through on B12 or folic acid, and so many different strategies to maintain side effects. But I think that in a summary question to you, Amy, what is your advice or guidance on talking with your pediatric rheumatologist or your nurse when you're feeling unsure or wanting to try something different, or even questioning, you know, whether the methotrexate's working or if it's been too long? And what's your guidance in just talking to your team about all these kind of questions we have coming in?
Well, I think if you don't ask the question, you won't know the answer. So that's something I read too in going through all of Abbvie's reports, is that I asked that question like almost every visit, especially in the beginning, like when can she come off of this? What about this? I've heard this. And they answered all my questions. And there's no certainty, like nothing is 100% certain, but every time I asked a question or Abbvie had a complaint, like we were listened to, and the doctors were very, and the whole team there is very thoughtful about how they respond. And I think at least where we go at Children's, like there's a recognition that it's not just about taking medicines, doing blood work, all that, range of motion. It's not just about that. It's about like overall kind of quality of life for Abbvie and for us as parents, and making sure that we're reassured and supported. And we always have been really well supported. And actually, I'm not doing a shameless plug, but I will. When we went to our first family day, I was like, oh my God, why haven't we come before? Like, it makes such a huge difference just to know that you're not the only person who's going through it. And I think there's a lot of value in sharing experiences and asking questions. I'm not afraid to ask questions.
Well, thank you guys so very much. And thank you to everyone who participated today and shared your own piece of yourselves and your story in our Q&A and our chats. Thank you so much, Abbvie. You continue to be just an exceptional, amazing, and much loved youth leader in our community. And I just so appreciate you taking the courage to speak tonight. Amy, thank you for all you're doing to raise awareness for Juvenile Arthritis Awareness Month. And please go read her post on Instagram, especially, we didn't get into it tonight, but your commitment to participating in research and belief in what research has done. And thank you so much to Dr. Guzman for being here for patients and families outside of what can be stressful and 2 short clinic appointments. And we so appreciate you being a part of Cassie and Friends to provide this information in a relaxed setting like this one, with everyone together, learning from not only each other, but from your expert medical experience and the amazing research you're doing to change the outcomes for good of kids with rheumatic diseases. So thank you so very much. So I have a couple short last words, but I only have just a few seconds. So I just wanted to say thank you so much again to our speakers. I'm going to share my slides here. Thank you again so much to Abbvie, Amy and Dr. Guzman. Really, really important. I want to let everyone know that we have a survey coming out right after this event, and your feedback is so important, not only to understand if you're getting the most out of these sessions, but also to let us know what future sessions you would like. We have a really exciting session next month on April 24th. It's called Rare Rheumatic Disease Talks. So we'll be taking a deep dive for families affected by juvenile dermatomyositis, lupus, vasculitis, and fever syndromes. And it'll be an amazing opportunity to hear from an expert speaker in each of those areas, but also meet other affected families. And then on May 29th, we have just an incredible speaker. Her name is Dr. Lisa Green, and she will be speaking on self-care for caregivers. So you're taking care of your child. How do you take care of yourself, and where do you begin? And she has amazing experience as a parent herself of children with chronic disease, and has written quite a few books on the topic, and spoke at a past Cassie and Friends Family Day, and just was amazing with so many good tips. And we'll have lots of opportunities to interact with others. Finally, please do feel free to keep the conversation going on our online support network. Thank you once again to our sponsors, as well as family and friends, especially now for Juvenile Arthritis Awareness Month. We do encourage you to keep in touch with Cassie and Friends to let us know how we can help you. And if you would like to keep seeing more sessions like this, and hopefully get back to live family days, as well as other Cassie and Friends youth programs, we do ask that you consider making a donation so that we can keep connecting, supporting, and educating our community, and investing in research for our pain-free future for kids that we envision. Thank you very much, and I hope everyone has a great rest of your Saturday evening. Goodbye.